Welcome to the DocTalks Podcast, a conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. I'm your host, Ian Gillespie, and I'm here to ask the questions and find the answers you need to know. We want to help our listeners know how to prevent and detect illness and how to navigate our healthcare system. Be sure to subscribe to the DocTalks Podcast to stay up to date on new episodes, and follow us on Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Hello, I'm Ian Gillespie. Welcome to the DocTalks Podcast, brought to you by St. Joseph's Healthcare London. According to the Public Health Agency of Canada, nearly 900,000 Canadian adults have experienced a stroke. Strokes affect each person differently based on where and how much damage is done to the brain, but there is hope. And today, I'm talking to Dr. Jamie Fleet, a physiatrist from St. Joseph's Parkwood Institute, and she'll be talking to us about the various treatments available to help people get back to their lives after a stroke. Dr. Fleet, thanks for joining us today.
Thank you for having me.
So right off the bat, we've had this once before. I hope I pronounced it correctly. Physiatrist. We spoke to, I think, one of your colleagues, Dr. Caitlin Cassidy, also a physiatrist. As I understand it, it's someone who deals in physical medicine and rehabilitation. Is that right? Can you explain what a physiatrist does?
Right. So a lot of people haven't heard of physiatry before, and for the most part, that's a good thing because we deal with a lot of serious injuries and diseases. But as you said, we deal with and try to help people with the physical aspects and rehab after they have something bad happen in their life. So that could be a stroke, spinal cord injury, brain injury, amputation, things like that. And so we work very closely with physiotherapists and occupational therapists, speech language pathologists, and others to try to look at getting people back their quality of life after they've had something serious happen like this, working on their function and quality of life rather than, yes, we've diagnosed you with a stroke, go on your merry way. We know there's a lot of serious complications that happen after stroke. So we try to look at the whole person, see how we can get you back functioning as best as possible.
So today, our topic again is strokes. And like a lot of people, I think I have what I think is a basic understanding of a stroke. I see it kind of like a heart attack in your brain, sort of a blocked blood vessel or something that stops blood flow to the brain. Am I correct? What is a stroke?
So that is a simplified version of it. But yes, there's two main types of stroke. One is, as you said, the blocked blood flow to the brain, and that can be from a variety of reasons in and of itself. But then the other type of stroke that's a little bit less common is when you have a bleed in your brain as well. But all of those result in damage to the brain tissue, which is pretty important for moving around, seeing, thinking clearly, speech. So those things can all be affected after a person has a stroke.
And I was a little shocked by this statistic that our producer, Kelsey Brake, put down here, that a quarter of Canadians living with strokes are under the age of 65. So it's not just an old person's condition.
No, and I feel that we're moving a little bit younger, unfortunately. The average age at Parkwood is around 70, but there's definitely a lot of people that we have that are younger. Sometimes women, when they're pregnant or in childbearing years, have some elevated risk factors for stroke associated with that. So those affects those people younger. Unfortunately, sometimes I've had a few patients in their 30s for different reasons as well. So for all kinds of reasons can exist that you can have a stroke, but it is unfortunately not just a problem of older people.
So let's quickly go into what are some of the causes then of a stroke.
So there are lots, but some of the more common ones would be atrial fibrillation. So that's an irregular heart rhythm that can sometimes produce blood clots, which can travel up and block the blood flow in the brain. That's why some people would be on a blood thinner to try to prevent that. Other common causes would be high blood pressure. So that can cause either the bleeding type strokes or the lack of blood flow type strokes. And then sometimes people just have a accumulation of different risk factors. So high blood pressure, diabetes, high cholesterol, maybe smoking, things like that all sort of wreak havoc on our blood vessels over time, and they get a little bit narrower and a little bit narrower and a little bit narrower until you don't get enough blood flow to the brain. And some of the other ones that for the hemorrhagic or the bleeding type strokes can be if you had a aneurysm or some type of abnormal blood vessels in the brain that can sometimes rupture.
So very similar to the risk factors for a heart attack.
Absolutely.
And how can we reduce some of those risks? I guess the same strategies you'd employed to fight heart disease. Am I correct?
Yep, absolutely. So there's a difference between primary prevention, which is trying to prevent a heart attack or stroke from happening in the first place, which obviously that's best case scenario. But by the time people get to me, that's not where we're at. So we look at secondary prevention. So that's preventing other complications down the line. So another stroke or a heart attack after your stroke, things like that. So keeping the blood pressure low, keeping the cholesterol in check, which can be from diet and medication, diabetes, keeping the sugars well controlled that way, which can be, again, diet, lifestyle with exercise as well as medications, being on a blood thinner if you do have this irregular heart rhythm. And then healthy lifestyle is a really big thing that everyone can do. Sometimes you don't know if you have high blood pressure. You don't know if you have high cholesterol because it's not something, if you cut your arm, you cut your arm. You don't necessarily feel if your blood pressure is high. So lifestyle, including avoiding lots of processed foods, excess meat, excess salt can be helpful. Reducing alcohol intake, quitting smoking, physical activity, and getting a flu shot is actually something that they recommend now as well for prevention of stroke.
Wow. And what about the signs of stroke? I know there's this wonderful acronym FAST that helps people understand if someone that they know or themselves are experiencing a stroke. Can you talk a little bit about that?
Sure. So that was sort of the most common presentation of a larger stroke. So fast face is your face drooping on one side or a sort of abnormal position of your face. Arm is your arm weak. Speech, and then T is for time. You need to get there ASAP because there are different interventions that can be done acutely when you get to the hospital to break up the blood clots or retrieve the clots. But those can only be in a certain window after the symptoms come on. That's not all strokes, but that would be the most common and sort of as a general rule. Sometimes people will have blurred vision or lose vision on one side of their eye or notice coordination difficulties depending on where the stroke is. So they're having trouble walking, they're having trouble, doing fine motor movements, but the one-sided weakness and the speech deficits are really big ones that you should really get to the hospital ASAP.
And you talked about a kind of a window that opens there, I guess, for that we should seek treatment quickly. How big a gap of time is that? How quickly do we need someone to get attention if they are experiencing a stroke?
So within about 4 hours. So you need to ASAP. And so the EMS ambulance drivers are really good. And even the people that the 911 dispatchers are really good at, if you say, hey, my husband, daughter, sister is having speech difficulties and arm weakness, then they make sure to prioritize you. And then they call the hospital ahead of time to activate what we call a stroke protocol. So everyone's sitting there waiting for you to get there so that can be done as soon as possible to try to prevent damage to the brain. Because sometimes it's lack of blood flow, but the tissue isn't totally dead yet. So we can try to salvage things as we can. And then that's associated with better recovery.
Right. So if someone thinks they're experiencing a stroke, they arrive at the hospital. What you talked about this stroke protocol. What happens? What are the sort of initial steps of diagnosis and immediate treatment?
So you're seen by a neurologist. They do a physical exam. They make a decision based on their experience and training, whether they think you're having a stroke or whether the story sounds enough like a stroke or not. You would get an urgent CAT scan of the head, and that would be to see if there's already a stroke that's there, because we can see some early changes with the imaging, and to make sure that it's not a bleeding type stroke, because we wouldn't want to give you any anti-clot medications if you already had a bleed, because that could make the bleed worse. So you'd have an urgent scan of your head, and then once that's done, then lots of blood work would be done as well. Keep the blood pressure under control, and it sort of depends on what the results of the CAT scan show after that.
Right. And then I guess would embark on treatment and rehabilitation, which is
Right.
So obviously, I guess the severity of the stroke can vary greatly, correct? From person to person.
Yes.
So generally, what are some of the long-lasting effects of stroke? Again, knowing that this varies from patient to patient.
So some of the long-lasting effects we see that others can see if you were walking around the grocery store, walking around the mall, and you would notice, hey, that person maybe had a stroke, you could see arm weakness or leg weakness that may result in limping or holding the arm in a certain way, sort of arm in to the chest, things like that. And that can be associated with what we call spasticity, which is an increase in muscle activation because of abnormal communication from the brain to the arm, more or less. So that's something that can interfere with recovery. People can have difficulty with speech and language long term, so they may not be able to get the words out that they want to use. They may use different words instead and sort of mix up the words. People may have problems with their memory. So that could be things like not knowing what the date is or where they are necessarily, or in the longer term, thinking, learning new things or remembering things from a long time ago. People can have difficulty with feeling like their sensation. They may have lack of sensation in that arm, which can affect how you're able to use that arm or how you're able to use the leg. And sometimes we see things that others can't see as well, like swallowing difficulties. So that some people, when it's severe, may require a tube to be fed through their stomach. Or post-stroke depression is also something that's quite common and probably under-recognized as well. So that can really interfere with someone's recovery. It's hard in the early stages after stroke to cope with that. Your life may be different now if you can't walk the same or you can't dress yourself the same or you have to rely on others now. But then even longer term, because of some of the changes in the brain and medications, everything else that's happening, post-stroke depression can happen in about 50% of patients as well.
And so as far as rehabilitation and treatments, again, because there's such a wide range of symptoms that can be experienced, I'm sure there's a wide range of treatments. Can you walk us through some of those long-term rehab efforts?
Sure. So people, as you alluded to, some people, the severity is quite variable. So if you have a really mild stroke, often you don't come to an inpatient rehab facility like Parkwood because unfortunately with resources and everything, we can't offer a bed to everyone. So if you have a very mild stroke, then you will see the outpatient stroke team. We deal with specifically more of the moderate to severe strokes on our unit. So we have physiotherapists, occupational therapists, speech language pathology that can deal with both swallowing as well as teaching people to learn how to talk and communicate again, as well as recreational therapists. So they're the ones that help with things like getting you back out in the community, teaching you how to take the bus. If playing cards is something that's really important to you, they can practice doing those things and doing sort of the community reintegration, as well as nursing and pharmacy. So people that come, we have 2 different gyms on our unit. So some that work on walking, we practice stairs, we practice balance exercises, as well as some more cardiovascular type exercises as well, sort of like a stationary bike, because that's really important too. Because as you said before, the similar risk factors are heart attack and stroke. It's important to get the cardiovascular system working as well. And then our other gym is more for occupational therapy. So that's where they do things like medication sorting. They can practice finances and how to write checks or how to pay your bills, practice those types of things. Shape sorting, which is important. We don't think about that. You think about that when you're a little kid, but you don't think about that in day-to-day life. But things can sometimes be important to relearn after you have a stroke, as well as working on some fine motor movements and getting dressed, doing up buttons, brushing teeth. Sort of everything they do from when they wake up to when they go to bed is part of the rehab, because that's what it'll be like when they go home. They're going to have to get out of bed. They're going to have to get dressed and brush their teeth, and that may look a little different than how it used to. So practicing all of those things every day that they're here.
Wow. And again, all these questions are dependent on the fact that, of course, there's a range of severity that it can affect people. But, I mean, is it possible to make a total recovery?
Some people do make a total recovery. And so the less severe your stroke was or more mild, the better chances of that are. And you may not be 100%, but you may be pretty good. Lots of my patients go back to work. They go back to driving. So there's significant recovery is possible. But unfortunately, we don't see that in everyone. I typically tell people the biggest gains in recovery is in the first 3 months. That's where you make make the steepest gains, the biggest progress on a day-to-day basis where you're really like, yes, that's a difference than it was yesterday. Month 3 to 6, you're still definitely making gains, but maybe it's hey, I'm better than last week rather than I'm better than yesterday. Month 6 to 12, it slows down, but still making recovery there. And that's where we work more towards compensating for some of our issues. And then after about a year, that's sort of what, as a general rule, we tell people, this is probably what your new baseline is like.
Right. So does the average sort of rehab program last about a year, or how long is someone going to be in a program recovering?
So the inpatient stay, people tend to come to us on average, and there's lots of other circumstances that surround that, but on average about a week after their stroke. And typically people will stay about 2 months, give or take. If they're really severe, but they're still making gains, they can stay for longer. If they get here and things are going really well, then we don't keep them any longer than we have to. Then people will transition to an outpatient stroke rehab. That can last a few more months. So again, depends on the people, 3 to 6 months. Sometimes they come to Parkwood again for the outpatient unit here. Sometimes we have a team that goes directly to your house if you live by yourself and you don't have anybody to drive you here, for example. But it doesn't tend to last the whole year. Ideally, it would, but just for resources and things like that, we're not able to help everybody just because so many people have strokes. They've made significant advances in medical treatment of people that have a stroke. So now people are surviving their strokes when before people died a lot more often. So we're doing better overall, but things have to be revisited, I guess, in terms of resources now that a bunch of people are surviving after their stroke to try to help them going forward.
Right. And those sort of improvements in treatment and care, is that something we've seen in like the last 20 years or something?
Probably around the last 20 years. So
Yeah.
that's with the clot busting drugs, as well as even more recently than that, the sort of clot retrieval procedures that you can do.
And then I think you mentioned earlier that one of the concerns, of course, is to prevent a second stroke and how doctors go about that.
So we work really hard on that when you're on the inpatient unit, keeping the blood pressure within a target, keeping the sugars within target. The cholesterol is more of a long-term picture, but try our best to do that. And then so adjusting different medications that way, providing lots of education. One important person that I forgot about in my list of people earlier was a dietitian. So the dietitian meets with everybody on the unit to talk about a healthy diet after stroke. So whether that can be tailored to the person. If you have diabetes, taking those things into consideration, as well as different dietary restrictions. If you're vegetarian, that's going to look a little bit different, those types of things. So working on those things. And then going forward, they're seen typically after they're discharged by a neurologist again. So they will assess if anything needs to happen there to prevent another stroke from happening. And then typically seen by a physiatrist as well, who focuses more on if there's any issues that came up with function or quality of life after they left the inpatient rehab. So as I said before, post-stroke depression is quite common, or this spasticity and posture of your arm or leg can sometimes take a little while to come on. So when we see them a few months after they're discharged, we can reassess those things to try to improve people's function and quality of life as best as we can. And then there's also the long-term management by the family doctors, which I think don't get enough credit overall, but they're the ones that are seeing people on a sort of more day-to-day or month-to-month basis to keep the blood pressure still under control long-term, monitoring the cholesterol long-term, monitoring the diabetes long-term.
Right. And we didn't mention caregivers. I mean, obviously, this poses a significant challenge for family
Absolutely.
members, particularly seniors who might be with one spouse or partner. Does the St. Joe's Parkwood Institute there offer any support to the caregivers themselves?
So absolutely, that's an excellent point. And caregivers don't get enough credit either because they take on the brunt of things. So when people come to the inpatient rehab unit, we often have caregivers come in for education. So that can look like different things, but come in to watch a physiotherapy assessment and a physiotherapy session. And then we can teach you how to transfer them from their bed to the wheelchair, or transfer them from the wheelchair to the toilet, or help them walk with their walker, help them go up and down the stairs. So we do lots of education around that, as well as education with other members of the team. So discussion on medications and diet and cooking, and as well as what's safe. We often have a family meeting as well, where all of those people I mentioned before will meet with the patient and other family members to sort of give a state of the union of, hey, this is your loved one's new baseline. This is how we think they could be most safe. You should look at installing grab bars or a ramp or whatever, depending on the house. And sometimes the occupational physiotherapist will actually go out to the house to do a home assessment and say, hey, Ian, this bathroom is not going to work for this. You need to get a commode here, or hey, you have too many stairs. Maybe you need a stair lift. So there's lots of different support for caregivers that way. Another important person I forgot on my list are social workers. So they work quite closely as well. And they're one of the liaisons between the family and caregivers and the rest of the team. So they help coordinate a lot of these things as well. So they're an integral part of the team. And then going forward, similar things exist when they do the outpatient rehab as well. And I would say when patients return to clinic with me, most of the time they will bring a caregiver who has, we go over questions and go through everything together because it is a family unit and physiatry is big on quality of life. So that involves everyone in the family.
A stroke is a brain injury, an injury to the brain. So how important is it for caregivers to understand that their loved one, the patient, may not be the same person that they were before?
So that's really tough. And that's where a lot of the education comes in to both patients and caregivers, because sometimes the patient expects things to sort of bounce back. And even if they're up walking and talking, that doesn't necessarily mean that their brain is firing on 100% like it used to be. So it's important for patients to know that, as well as caregivers, as you've said. So one thing that we really try to hammer home is pacing. So this can help with a lot of different things. It's going to take longer for you to do most things that you did before, especially in the short term after your stroke. So getting dressed, making toast. You have to think about all of those things. As adults, we've learned how to do that. I don't really have to think about how to make toast anymore. But if you really boil down all the steps, you have to go to the cupboard and get some bread. Put it in the toaster, put the toaster down, go get some butter, go get some peanut butter, what have you. There's a lot of different steps that really go into that. So when you have to relearn how to do those, whether it's physically or cognitively, and think of each step, that can take a lot more time. It can be frustrating. So that everyone understands that this is a major change in the brain. It can take a long time to recover. So even if you can't make toast tomorrow, maybe in 6 months from now, you will be able to make toast. So trying to educate on pacing, taking your time, scheduling breaks throughout the day. Another important thing is if you have something imperative to do during the day, so you have to go to the passport office or you have to do a doctor's appointment, trying to make it early in the day when you're most well rested. So that's one of a big thing that we really try to educate patients and caregivers about as well is the pacing aspect, because the person may not be the same person that they used to be.
You were mentioning how, of course, treatment has improved. People, I imagine, are recognizing this quicker now. The success rates, survival rates have increased. Is there something on the horizon, some new developments in treatment and rehabilitation?
So one thing that I think is sort of been started, but I think is going to advance significantly going forward is looking at biomarker prognostication. So we have a general idea. If you show up and you have a very, very, very severe stroke based on your physical exam as well as the findings from the CAT scan, we can say with relative certainty, things aren't going to go perfect here. We don't expect you to be up walking around, returning to work, being completely independent. On the other end of the spectrum, if things are fairly mild, we can estimate, hey, things should progress significantly. We don't have a crystal ball, so it's hard to estimate that perfectly all the time. And that's sort of the rule, but there's always exceptions to the rule. That said, one thing that researchers are working towards now is biomarkers. So whether that can be different blood findings or different findings on imaging, so on MRI or different types of scans, that if they show up a certain way, you have a better prognosis or worse prognosis. And then we can tailor that for rehab, because you have a better prognosis. So we try to get you into rehab and optimize that as much as possible. Versus the other hand, we don't think you're going to have meaningful recovery. So maybe your rehab might look a little bit different, or you go to a longer term, slower, less intense rehab because of your prognosis overall. So that is one area that I think is going to be expanding going forward. And we may even be able to figure out one day, hey, based on your stroke affecting XYZ area, and these biomarkers, you may do better with this treatment or this rehab. You may do better if we focus on the cardiovascular bike, or you might do better if we focus on balance training. So I think that that's an exciting area going forward, but still very new right now, and just in the research realm. It's not being used for everybody yet.
How can people get involved in the research that is going on at St. Joseph's?
So I specifically do a lot of research. I'm about 50% research in my career. So there are lots of ways to get involved with that. So for donations, for example, through the St. Joseph's Healthcare Foundation, that's typically how that can be done. And then if patients want to get involved, there are some research studies that are ongoing while they're on the inpatient rehab unit that often they can be approached. We have different signs up, things like that. But typically it's the team that sort of says, hey, I think you would be a good person for the study, and then brings it up that way. And then similarly, as an outpatient unit, we have a lot of different research coordinators that will come down and sort of loiter in the outpatient area. And we say, hey, I've got a patient for you for this study, or hey, I've got a patient for you for this study. So I think St. Joseph's in general is a big research institute, and I think that that's fantastic. So it's a way for patients to sometimes get additional therapy that they may not have been offered, or different things that we're trying out that may help recovery overall. So I think that it is fantastic to work at an academic center like St. Joe's to have those options.
We've covered a lot of topics. Is there one kind of central thing you'd want people to take away from this? Maybe one misconception that people generally have about stroke, or one piece of information that it's important for people to know?
That's a tough one. I think that one thing that is important for people to know is having a stroke doesn't necessarily mean a death sentence. And that sounds very sinister and kind of cliche, but it used to be. But for the most part now, a lot of people do survive, and a lot of people do make meaningful recovery, that they can go back to living on their own and or working, driving, those types of things. So it doesn't mean that things are over. There's a lot of advances that we've done, and physiatrists can really make a big difference in recovery overall. So if you haven't heard of physiatry yet, Google it, and we can try to help after stroke.
Absolutely. Good to know. That's a nice optimistic note to end on, I think. Dr. Fleet, thanks so much for joining us and increasing our knowledge about stroke.
Thank you.
That's it for this episode of the DocTalks Podcast. Thanks for joining us, and join us next time when we'll continue our conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. Be sure to subscribe and follow us on Facebook and Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Until then, stay healthy.